Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national not-for-profit, publicly funded single-payer healthcare system, commonly referred to as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, and long-term care, as well as mental health care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud so you can listen anytime. This radio station relies on volunteers like me and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and Jean Shively join me as co-hosts with their special guest, and the topic is improving cancer treatment in rural hospitals. Let's get started. Dr. Flynn?
All right, this is Michael Flynn. I'm a retired surgical oncologist from the University of Louisville Surgery Department. Let me begin with the usual disclaimer. Any comments I make represent my personal views and do not represent the views of the surgery department or the University of Louisville. Our topic for the program today is how the Markey Cancer Center networks with rural hospitals to establish cancer programs. And I am personally especially interested in this because back in the 90s, for about 5 years, I had an administrative position at the Brown Cancer Center dealing with community relations. So we have a special guest today. Dr. Timothy Mullett is a professor of thoracic surgery at the University of Kentucky at the Markey Cancer Center. He's the medical director of the Cancer Center Network program. He got his MD degree from the University of Florida at Gainesville and did residency and fellowships in surgery and thoracic surgery at the University of Florida in Gainesville. So, Tim, first of all, I want to thank you for your willingness to come on and talk about this very interesting issue. As we've done with our past guests, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them, and then Jean will begin the conversation. So, Tim, the floor is yours.
Well, thank you very much. It's great to be here, and it's a privilege, really, to be able to speak with you, Mike, and your history at Louisville, and appreciate the opportunity to get together. And Dr. Shively, it's always important to see you and impressive to see the work that you've done in Campbellsville, and have really been a beacon for understanding the importance of rural surgery. And you know, it's really those interactions with the rural programs that got us so interested in expanding what began at Markey Cancer Center almost 20 years ago. In 2006, the network was initiated really as a chance to. We didn't have enough room for our oncologists to practice, and so we were looking for places for them to be able to have more clinic space. And so they went to 3 different hospitals in eastern Kentucky and began practicing there. And you know, that was actually helpful for us to get out in the community. We could get to at the time it was Cynthiana, Harrison Memorial, Rockcastle in Rockcastle County, and St. Clair in Moorhead. And so, you know, there we were practicing, and our oncologists were actually delivering care. And so it was an experiment at the time out of necessity, and then it became a bit more of a marketing piece to be able to grow our program and to for other programs that wanted to be connected with us. And so we had expanded our clinical capacity, and we didn't need oncologists out in the community, but we did want to connect with mostly rural oncology programs. And so by about 2013, while we were busy developing our NCI application to become an NCI designated program, we had about 8 programs that were in the network at the time. And after we developed NCI designation, then all of a sudden it became more important for the network programs or for the community programs to find a way to connect to Markey. And so we began to really grow the program to about 13 or 14. And then at about 2014, I thought that, we're hanging our sign, just like you were working with community hospitals, Mike. We were hanging our sign out in the community, and we thought that it was really important that we would have a way to be able to define the quality of cancer care for the programs that were being represented by our work. And so we, at the time, I was becoming more engaged in the Commission on Cancer, and I thought it was really important that we could say that all of our network sites had to be COC accredited. The Commission on Cancer is a national organization under the quality programs of the American College of Surgeons. And so it represents the gold standard for quality cancer care. And all programs, whether it's an academic or an NCI program or a community facility, can achieve compliance with all of those standards. And so we thought that would be really important for us. And that really turned on what we found to be so powerful in our network, which was not just making connections for marketing purposes or for clinical care or finding a place to have a clinic somewhere or something like that. It was really driving quality in the community. And so when we began to mandate COC accreditation for membership in our network, we also said, well, we have to help these programs achieve COC accreditation. And that was what was really impactful for us, is getting out into the community programs and working with their facilities, working with their administration, with their nursing, with their physicians, pharmacy, all the way through, and establishing compliance for all of the 38 standards that we have in the Commission on Cancer. And so that really allowed us to help these programs improve the quality of cancer care they were delivering, so that more patients would be comfortable staying in the community rather than having to drive to Lexington or Louisville or someplace else to a larger program. And so this was really impactful for us. Once we became NCI designated at Markey Cancer Center in 2013, and then we achieved comprehensive cancer center status in 2023. That was our mission. Really has been to increase access to research and increase access to or increase our impact in our catchment area. And since we're the only NCI cancer center in the state, our catchment area, as far as the NCI is concerned, is the entire state of Kentucky. And so we have to have a way to show impact in that by working, not with our own programs. It doesn't help us to say, send your patients to Lexington, send your patients to Markey. It helps us to say that you can get quality cancer care in your own community, and we can help you do that. So that's kind of how the network has evolved, and it's really, I think, on a trajectory for even further evolution to expand research access for folks right in their own communities.
Well, that's great. Thank you very much. I think it'll help our listeners understand how this got started and how it's working. Gene, do you want to begin the conversation?
Yes, sir. This is Eugene Shavely. I'm a retired general surgeon, a rural surgeon in Campbellsville, Kentucky. And again, what I say is that of my own opinion and not that of the University of Louisville or the Taylor Regional Hospital. Um, we have been affiliated with the Markey Cancer Center for I think of 5 or 6 years, and I'll just say a little bit about our own rural cancer center. It was started around 20 years ago, but we actually started doing chemotherapy in the early 80s. We started them out of the emergency room, and then we had a medical oncologist that came down uh, twice a week and saw patients, and our nurses gave the chemotherapy. We expanded that into an office building, and then we had patients that were going to Louisville for radiation therapy in a van, and this was working, but it wasn't ideal, particularly having to ride in a van all the way to Louisville and back, and waiting for other patients to be treated, and patients who were not feeling well or nauseated and vomiting, and you can imagine the problem. So we were eventually able to put up our own cancer center. We became certified, and it's been a great trip. Um, we now can treat majority of our patients in our catchment area, which is we estimate about 100,000 people from surrounding counties and Taylor County. We can give most of the chemotherapy, and we can give almost all the radiation therapy. We have a new linear accelerator, and this makes it much easier for patients. We have some patients that have difficulty just getting 20 miles to us because of transportation or gas money. And so it really makes it convenient. And we've really picked up the number of patients uh, who are getting radiation therapy in our linear accelerator. I cover over there sometimes for the radiation therapist. I don't see patients, or obviously I don't outline the therapy, but it's a law that a doctor has to be in the building, so I see what's happening. And our chemotherapy unit is really doing an outstanding job uh, with giving chemotherapy and taking really good, compassionate care of the patients. All our nurses are certified as cancer therapy nurses, and we're really proud of that. The Markey Cancer Center has helped us in some of the administrative roles for the Commission on Cancer. Some of the requirements are difficult for a small hospital, but they've really helped us to do that, and we've been passing our inspections for the last few years without any problems, and they've really also helped us in doing some research programs. It's required by the Commission on Cancer that you have a small percentage of your patients involved in clinical trials, and they've helped us with do that. Now, we send patients to tertiary care centers for things that we can't do, for example, bone marrow transplants, or if we have a patient that has to have a very large operation, like a pancreatectomy, then we don't do those here. It's been a win-win situation, and I think that we have really solved a tremendous problem with disparity of care between rural and patients who don't get care in rural areas because they don't have access, and now they have access, and that has been super. Um, I just recently learned that University of Kentucky and the Markey Cancer Center has been a model for getting uh, cancer care out into rural areas, and the state of Iowa is trying to copy the model that Kentucky has done. And I'd like Dr. Mullett just tell us a little bit about that and how that worked.
Well, thank you, Dr. Shively. Yes, this is a this is a great opportunity for us. Our network has developed, has become recognized by the NCI, and I had the opportunity to present in Washington at the National Cancer Institute and about our network and a conference called Accelerating Rural Cancer Care. And when I did that in 2017 or so, in the audience were some of the leaders from the University of Iowa Cancer Center, the Holden Cancer Center. And they talked to me after the conference and said that they were very interested in learning more about what was happening in Kentucky and how this was working. So they began a process of an NCI grant that actually studied Markey Cancer Center's network, and that led to a publication, but it also led to them describing the methodology that we were using in reaching our rural cancer sites. And so after they identified that and then began to think about how that could be deployed in another state like Iowa, they began to contact community programs that were not COC accredited and were interested in trying to expand and enhance the quality of cancer care that they were delivering. And so in that setting, they've really reached out now initially with 3 or 4 sites, and now it's 6 or 7 sites that they are communicating with, and they've been able to help at least one of those programs achieve COC accreditation. So the grant that they have from the NCI, we are a part of that grant. So this is fully in collaboration with our work. Our staff members are serving as consultants with those in Iowa to work hand in hand with them at developing their program, evaluating the progress that they're making, and helping them make changes as they're going forward to be able to advance their application in Iowa. So and they in fact just had, as when they first began this process, the team from Iowa came to Lexington for our annual conference, and they had the chance to interview folks in our community sites. And they interviewed our staff and others to be able to figure out what the secret sauce was at the Markey Cancer Center network. And so when they actually continued to develop their program, and just last week hosted their first annual cancer conference to attract members of their network and to have external speakers and to be able to increase the education and application of COC accreditation in the state of Iowa. So it's really exciting to see what they're able to do. And they've actually worked with us and have another grant that is in application for considering how this could be expanded into other states. So we're particularly proud of the fact that we've been able to develop a process that will that looks like it's going to be able to expand into other locations as well. So we're pretty happy about that.
Okay, Tim, in the same vein, Gene has kind of outlined what activities are going on from the standpoint of cancer care at the Taylor County Hospital. Can you give us and our listeners a kind of an idea of what kind of specifics, cancer screening, education, chemotherapy, radiation therapy, or surgery that you all can get going in the programs in some of these other rural hospitals? Is it the same degree of activity that Gene outlined, or I mean, just give us an idea how that works in other places?
Absolutely. We have several features of our network. One is education, and so we actually in our annual cancer conference coming up on December the 11th and 12th, we will bring in sites, members of our sites in our network to come to Lexington to the Central Bank Center. It's a large conference, and they'll be able to participate in several talks from national speakers about contemporary cancer care, aspects of new models of cancer care, things that are impactful for the community, so it's a great way for us to be able to share that knowledge. But additionally, we have other opportunities for our network sites in education. We have a physician masterclass. Dr. Shively's been on that call several times, and we have physicians from across the state that participate, and we have speakers from Markey Cancer Center that will have a conversation much like this about a particular education topic, and they'll run through an education concept with slides and the presentation, and then there'll be time for discussion. We also work with not just physicians, but with the staff at the pharmacy and nursing and social work and all of the components of cancer care. So education is a big part of what we do. Quality of cancer care is really, we use as a baseline COC accreditation. But as you mentioned, screening, we are really pushing for enhancing screening in our sites. And so we've been talking with them for several years about the importance of lung cancer screening. And in fact, we collaborate with a research project that we have at the University of Kentucky, and where we've developed a process to evaluate lung cancer screening programs. And we're actually deploying that through most of our network sites to be able to evaluate their screening program and then provide opportunities for improvement in different areas. And then finally, as Dr. Shively mentioned, we host a nurse liaison program, which is a team of cancer specialized nurses that have the opportunity to work both with Markey Cancer Center and our sites. And so when patients need those higher level of care, such as the pancreas surgery you mentioned, Eugene, or the maybe it's a rectal surgery or complex surgical care, bone marrow transplant, or some of the cellular therapies and that are becoming available that have a certain complication rate that's pretty high. And it's certainly important for us to make sure that we're optimizing what we're doing. So instead of a rural cancer program doing one or two esophagus operations, they can come to our program for surgery where we're doing 40 or 50 of these operations a year. And so our team is well versed in taking care of patients with that. But chemotherapy and radiation therapy can be done right in the community. And so our nurse liaison team really helps to coordinate getting that care done. So we'll see the patient, talk to them about surgery, tell them that they need radiation and chemotherapy before surgery, for example. They'll get that in the community, and then they'll come back and see us for surgery, and then go back to the community for any follow-up care. So we're really trying to define what is the right care that needs to be done in the right location. And so by concentrating some of these specialty care areas like bone marrow transplant, cellular therapy, immune treatments, things, some of the research trials that we have that might be very advanced first-in-human trials or phase 1 trials, things like that. Those need to be done at Markey Cancer Center. But when patients need conventional care, that can be done right in the community, and we're trying to increase the quality that's being delivered.
Tim, let me ask you a screening question that goes way back to the time when I had this administrative position at the Brown Cancer Center. One of the issues that we were dealing with, I also worked in the breast care center there for a while, was the issue of general radiologists reading mammograms, and the accuracy of a mammographer reading a mammogram as opposed to a general radiologist, or a radiologist who's had special training and focuses on mammograms can be quite different. Is that still an issue, and how or not, and how do you all deal with that in some of these small rural hospitals? I can't imagine they've got radiologists who specialize in reading mammograms in some of these small hospitals.
You're right. You're right. This is a challenge. And so some of the things that we've done has been back to education. And in my experience in lung cancer, for example, we've had our radiologists help with talks and trying to enhance reads in lung cancer screening. And so that involves a low-dose CT scan. And it's a very quick study. It only takes about 15 minutes, if that. And the patient doesn't get any contrast or anything, but reading it, to your point, is different than reading typical CT scans. And so being able to work with education and enhance that is part of it. And that's part of our measurement of lung cancer screening programs as well, is making sure that there's a level of experience of those folks that are reading it. So while we have done overreads for facilities and assisted with being able to help them with some of the work. Now, as you know, it's a challenge with the volume of work that's being done at the University of Kentucky and Markey Cancer Center, or I'm sure at Brown Cancer Center as well. It was the same thing. You don't have a lot of spare radiologists that you can be able to spend their time reading mammograms or reading other images from other institutions. And so that is a challenge. And so working with those programs to find the best solution, whether it's an outside read of an expert, by an expert to read those scans, or whether it's improving the education and experience of those radiologists that are in the facilities, are two ways that we can work to try and enhance what gets done.
Let me address that just a little bit. For a long time, we had a Dr. Hart, who was really a fantastic radiologist, and we've been very, very lucky since the late 70s and early 80s and throughout today. We've had outstanding radiology. And Dr. Hart was really interested in breast mammography, and so she did an outstanding job and did all the invasive biopsies, etc., and needle localization. Most of our radiology now is sent off-site. We do have a radiologist that comes in and does invasive radiology 2 or 3 days a week, drains abscesses, and does breast biopsies and other biopsy for us. So we've kind of solved that problem in that if you have a special CAT scan that's difficult to read, or MRI, that's available to us offline, and that's been a great value to us.
Gene, I'm not sure I understand. Do you have a radiologist who specializes in reading mammograms, or do you refer those out, or do you just refer the ones that seem to be difficult or confusing out to be reviewed by a specialized mammographer?
Up until about 3 years ago, we had a radiologist who was very, very good at mammography and breast radiology. She's retired now. I think a lot of that is being referred out now, but we still have someone who can do needle localizations and breast biopsies, and I don't think we've had a problem. Another thing that's really interesting that's happening in mammography that artificial intelligence is playing a big role in that. And we have two new mammograms, and we're really picking up our screening. And the number of people that being screened is almost doubled now.
You know, Mike, you really raised some good points about how do we deliver cancer care in the rural community, given the deficit that we have in several areas. I mean, we can look at the number of medical oncologists that we are short in rural areas across the country, and how are we addressing that, for example? Similarly, with radiology and even pathology, and so learning, I think this is one of the silver linings of the pandemic, is the being able to learn more comfort with virtual technology and being able to have virtual reads. And I think we're all really raising our expectation. I think we can all remember that there were times that we've had external reads for radiology that we didn't really have a lot of confidence in, because they may have been read overseas, they may have been read and we didn't really have a knowledge about where the level of training and experience was. And so, but I think it's caused us to have comfort in raising those questions, asking about the quality, asking about the experience that they have. But leaning on tools such as AI, which is drifting into even lung cancer screening and CT scans, past mammography even, is a reasonable way for us to be able to expand the amount of care that can be delivered. But it requires human oversight, and it requires guardrails to make sure that we're doing that safely. And I think that's the real value of us all working together. And so even in our COC accreditation, just about all of the standards that we have the opportunity for programs to provide a service on site or by referral. And so whether it's pathology or radiology or radiation therapy, for example, those may not be available at all rural programs, but they are always available by referral. And I think that's another area that we've really tried to expand, is the comfort with referring out some of the things that can be, and we're even looking at ways to be able to work with sites and provide tele-oncology, so that a medical oncologist can be present in our facility and work with a local community program and their nurse practitioners to be able to see the patient, and then virtually see the oncologist, who has a chance to look at the pathology, look at the imaging, talk to the patient, go over all of the potential benefits and the potential harms from certain treatments, and then the treatment can be delivered locally. And so these are all tools that are coming to play to be able to expand how we can deliver quality care.
Okay, Tim, let me just take that to.
Let me say just one thing. We did not mention rural surgeons, and that's approaching the crisis stage. Nobody's going into rural surgery. The chief of surgery at U of L just recently said that nobody wants to work that hard. We're not training rural surgeons. Almost everyone is going into subspecialty, and that may be the real problem in the coming years in developing cancer programs and rural hospitals. Without a surgeon in a rural hospital, it's almost impossible to keep the hospital going. And so one of the things we've got to do is start developing programs where we can train surgeons into doing real general surgery and work in rural hospitals. And that may require even an extra year of training. There are programs around the country where that can happen. Even the Mayo Clinic's got a rural surgery track.
You know, Gene, this is the improving quality of cancer care in rural programs has been a focus of ours for a long time because of our practice in Kentucky, the majority of which is rural, but also how it can be translated to many other states that are also impacted. And if you look at COC accredited facilities, there are very few that are present that have COC accreditation in the rural communities. And in fact, it seems that Kentucky has the highest per capita incidence of COC accredited facilities in the country. And that's because of what we've done with trying to drive accreditation into these community programs and successfully done so, just like Taylor. But it's still a challenge for other programs. And so what we did was using some of our staff from the Markey Cancer Network and myself and others, while I was the chair of the Commission on Cancer, we put a strong emphasis on rural cancer, and we developed a special track for rural program accreditation. We aren't lowering the standards, but we are making it more practical for rural cancer programs that don't have the same number of people working in the facility. They don't have the same volume of care, but they still need to maintain a high level of quality. And so we've developed a whole new track for accreditation for rural cancer programs. And we are already beginning to see programs take advantage of that and begin to expand the quality of care. And many of the standards depend on surgical intervention. To your point, having a surgeon available in those facilities, either present in the facility or by referral, and making sure that they follow the standards and the high quality cancer care is the expectation.
Tim, let me ask you to let's focus on these issues from a slightly different perspective. As we all know, many rural hospitals have limited resources. Multidisciplinary cancer care can be expensive, and the issue about specialists. How do you manage those issues how do you help the rural hospitals manage these issues from a financial standpoint?
Well, that's an important question, and it's very important for us to understand. And as we are working with these facilities, that we are trying to advance the sustainability of what we're doing, even in their rural setting. And so, to be honest, that's answering that type of question is the reason why I went back to school and got my MBA, because I needed to speak the language of the CEOs and the C-suite, so that we could talk to them about the advantages of both membership in our network and understand their challenges. And so we've worked hard with them to try to make sure that we are, again, through opportunities like tele-oncology, opportunities through better education, participation in our network is a membership. There's a fee involved in that, and we have to provide value for that fee. We have to provide an advantage to these local facilities, and so we're doing that through assisting them through COC accreditation, assisting them with optimizing their care, and some of that is sometimes consultations with our own faculty at Markey Cancer Center, and working with them on expanding the services that they can offer, even expanding things like effective and efficient screening programs. And so what we're trying to do is to raise the value of cancer care and expand what they can offer. We can work with them to be able to safely expand the type of therapies that are available, then that's a revenue stream for that facility. If we can expand their ability to bring more patients in for lung cancer screening by increasing awareness and increasing understanding of how lung cancer screening works, that's a huge opportunity for programs, because it provides a downstream revenue for those facilities when the patients are found to have positive findings for lung cancer, aortic aneurysms, coronary calcification, other masses in the chest. And so there are plenty of benefits to expanding your screening program that can enhance your financial status. And so while we don't provide cancer care directly in these facilities as part of the network, we do work with them to be able to make sure that if we're going to take care of a patient for their surgery, for example, or their specialized care, we work very hard through our nurse liaison team to make sure that that patient goes back to the community and doesn't stay in Lexington for care that can be delivered locally. And so all of that's enhancing the bottom line for all of these facilities in rural Kentucky.
Well, let me take this. Let me take this financial issue another step further. We all know that the legislature in the national legislature, Congress, just passed the quote big beautiful bill unquote. I would call it something else, but I won't do that because Paul will get mad if I start using four-letter words. We had Jason Smith on. This is would be largely sort of paid for by defunding, or not totally defunding, but largely defunding Medicaid. We had Jason Smith on a few months ago, who is the current CEO of U of L Health, and he told us that when the first Governor Beshear expanded Medicaid, the non-paying patient population to U of L Hospital went from 20% down to 5%. And then they have some real serious concerns about the financial issues that a safety net hospital like U of L Hospital is going to encounter with these Medicaid issues. And it may not be a fair question to ask you, but I'm going to ask you anyhow. What kind of, you're predicting the future, what effect is this going to have on these cancer programs, screening and cancer care in all these rural hospitals that you've been networking with?
That's a great question, and one that we're paying close attention to, because we do have to understand that Medicare and Medicaid provide the majority of coverage for these rural cancer programs. And just like at University of Louisville, there's a large segment at the University of Kentucky that's being seen and covered by Medicaid. And that we had the same thing where we, in 2014, with the advance of the expansion of Medicaid coverage, then we had a significant drop in our self-pay or those uncovered patients. And that was exciting and great for us to be able to have that level of coverage. It's also expensive, and so it's to the state. And so being able to find that right spot for where Medicaid patients are and where they can receive their coverage, we have strong support from financial assistance to be able to get the right patients back into Medicaid if they've let it lapse or if it's otherwise not covered. And cancer certainly provides some opportunities for being able to expand eligibility for Medicaid. And so we want to work hand in hand with these programs to try to optimize that. There are other cuts that are present, and I think we've all seen that the actual cuts from Medicaid have not been as draconian as were initially proposed. Even the cuts to the NCI funding were not as dramatic. They were predicting a 40% reduction in the NCI funding for cancer centers like ours and for expanding research. And in fact, as the budgets have advanced through the Senate and the House, we're actually increasing coverage for Medicaid or for NCI funding. And so I think that there will be a pendulum that will swing. The conversation went pretty heavily against describing, as you said, the partial defunding of Medicaid, and really, I think what we're getting to is right sizing the Medicaid rolls and making sure that the right patients are listed, and that we are able to cover the patients that truly need this. And so I think that we're going to see that especially in Kentucky, where Medicaid stands as such a high value for us. There's been a lot of focus on this from all of the C-suites to be able to optimize this. So I'm hopeful that we aren't going to see dramatic reductions in the number of patients that are truly covered by Medicaid, or at least certainly won't see any decrease in those that are eligible. So it's so important for us and the populations that we take care of, both those patients that need specialized care, such as that can be done at Markey, and that taking advantage of that which can be delivered in the community. So I'm hopeful, but it's certainly something that we have to keep a close eye on. Medicaid was not the significant cut, I think, that we've seen across the state. There have been other changes in funding that are going to be a challenge, but we will continue to work side by side with our community programs to try to optimize what care they can deliver and what we need to do.
Well, I hope you're right about that, and I hope those issues penetrate the brains of both the Kentucky and the national legislature.
Jason Smith was in Washington the first part of this week, talking to our legislatures. I know indirectly that he feels that it's a very, very significant problem with the ACA and Medicaid for the University of Louisville and its outlying hospitals.
Tim, let's carry this financial issue a step further. A number of hospitals around the country and around our state have been purchased by private equity companies. These organizations are not focused on health care. They're focused on profit. They buy out things. They provide the materials and maintenance in a lot of an assortment of ways. I'm just wondering, have you had experience dealing with any of these issues, and how's that been working?
Yeah,
If
yes, sir.
if you have, if you haven't, then we can move on to something else.
I think it's important that our network does work with public facilities as well as those that are quote for profit, and those corporately owned facilities such as LifePoint facilities or others. They do have an answer to shareholders that they need to provide. But I've been really impressed with their focus on trying to enhance the quality of cancer care. They've also embraced the COC accreditation, and I would have thought that would have been a casualty early on. If they're trying to save money, then why not pay for things like COC accreditation, or pay for things even like the Markey Cancer Center Network. But to be honest, we've had a very loyal group. We've had folks that have recognized the value of what we're doing and maintained that even in times of financial trouble in many settings. And so I think that they see this as a way. Well, let me give you this example. When I was, I served in the Army Medical Corps for many years, for 27 years. And so I recognized when I was deployed in Iraq, we went to a part of the northern community of Iraq, and we worked on medical assistance visits with the local personnel, the local providers. And so we would go as Army physicians, surgeons, and other physicians to work with the local providers. And we found that the community, which was highly distrustful of the local providers, found value in the U.S. soldiers and physicians standing with them and providing some level of credibility at that level. And so when we left, they continued to see those local physicians because we provided some comfort in the fact that they were receiving care and that we were endorsing their care. I've seen the same thing in what we're doing in community facilities, where the local communities may have had some concerns about the providers in their care area and years ago, and had just switched their care to drive the long distances to Lexington or to otherwise have their care delivered elsewhere. And so when we were able to stand with these facilities, all of them, and stand by the quality of care that they're delivering, the community has begun to come back, and they are seeing these programs, and they are rising in market share in their local communities rather than driving cancer care toward us. And so it's actually imperative that we're improving the cancer care delivery in the community. That helps the financial status, that helps the patients decreases their financial toxicity for driving and trying to receive their care further away. And so I think that what we've seen is by standing with these communities, whether it's a for-profit hospital or a not-for-profit hospital, they see the value in what we're able to bring into their own community.
Well, I hope you're right about that with these private equity-run institutions.
We've been working with them for several years, and I think that there are the financial screws are tightening, and so it will be important for us to understand, and frankly, for us to continue to find ways to deliver value for the fees that we're charging. And I think we're able to do that because we really do focus on quality rather than the bottom line.
Gene?
Let me ask one other question about finances. Is the potential change in the ACA, so-called Obama plan, you think going to hurt our care, particularly in cancer, and the high premiums?
So you're talking about changing the subsidies that have been offered in the COVID era to the Affordable Care Act that were extended through President Biden, and they were slated to terminate this year. And so I think the delivery of those during the time of the pandemic, during the time of that degree of uncertainty was important. But I do think that what we're finding is that in fact the Affordable Care Act is not sustainable in its current model, and so not without continued subsidies. And part of that, back to your point, Mike, about firms with attention on the bottom line, the insurance companies that were supposed to provide this care began to run from the Affordable Care Act, and so they weren't actually continuing to support, the large insurance companies weren't continuing to support coverage for patients that were enrolled in those plans. And so they just became more and more expensive because of less and less competition and more dependent upon the subsidies, which were supposed to be short term. So what are we supposed to do with that when those subsidies run out outside of the pandemic? And we're supposed to see that this is indeed sustainable. And so I think that what that's forcing is a conversation in Washington that looks like it's trying to find better ways to deliver affordable care rather than leaning on the expectations of these subsidies. And so I'm hopeful again that we're going to be able to see improvements in the way that that's delivered. But I do think that it's a risk, and I think that if we can continue to emphasize that those subsidies will probably be required until we come up with a better solution to be able to help patients, because of the extremely high cost of those policies without the subsidies.
Tim, we're down to the last 2 minutes here. I want to ask you one more question before Paul takes us out. As you know, this is a program sponsored by Kentuckians for Single Payer, promoting Medicare for All. Would you share with us your thoughts about how, if we had a Medicare for All health insurance in this country that would affect your ability to provide cancer care for rural hospitals?
That's a great question. And, I think the devil is in the details with that, but I'm certainly excited to think about a way that we could be able to sustain that. I think that, even when we look at other countries that have embraced universal coverage, they still have a two-tiered system. And so I think that what we're going to find is that there's going to be a level of care that's going to be available for everybody if we embrace the Medicare for all. But I think that you'll find that what will happen, at least what has happened in the other countries, has been that there's a two-tiered system where a higher level of care, more expedited care is going to be available for a price. And go ahead.
Tim, I was just going to say thank you. This has been an excellent program. You're a great guest speaker. We're about out of time here. I think Paul's ready to take us out. Thank you again. This will be broadcast on Forward Radio either next week or the week before, and Paul will send you an email about when that happens. Paul?
That's wonderful.
All right, Tim, thanks again. I really enjoyed the talk. And also, has anyone ever told you you have a great radio voice?
Kay Wood-Leffert.
Hey, I watch a lot of these waveforms go across the screen, and I tell you, you've got a beautiful waveform, too.
Wow. I've probably got a face for radio. And,
yeah, I'm told that all the time. So,
yeah.
All right. Well, I guess you're free to go. And again, thank you so much for dropping in on us. And I'm sorry for the delay.
No trouble at all. I'm glad we were able to work it out, and thanks for giving us the full amount of time, and really enjoyed the conversation and the stimulating questions that you guys had. I think that we've got some challenges ahead of us, and working together, we'll be able to find a way.
Well, Tim, listen, maybe 6 months or so from now, if we give you another call, would you be interested in coming on again, and we can talk about some of these issues, when the political climate may be a little different?
I would be fascinated. I'd love to do that.
That'd be great. Yeah, we'll look forward to it. We'll put you on our list.
All right. Thank you again. You all have a great day.
Thanks, Gene and Mike, for bringing another wonderful guest on the show. And a special thanks to our listeners who tuned in to listen to us today, and I hope you continue to do so. I'm wishing everyone a wonderful rest of your day. Before we go, I'd like to remind you that Kentuckians for Single-Payer Healthcare and Forward Radio are both nonprofit entities, and we depend on your generous donations to keep us on the air. Tune in to Forward Radio anytime for a variety of entertainment and educational programs, which I'm sure everyone can enjoy.